Hello everybody, Dr. Alex Vasquez here again with the second video of today. And right now I'm going to focus obviously on this article, Implementing Effective Healthcare Reviews. This is from the Agency for Healthcare Research and Quality in the United States. This was published by the American Academy of Family Physicians in their journal, American Family Physician. So this is a really good journal for kind of taking the pulse of family practice medicine. I'm not saying, it's obviously not a specialty journal, it's just a practice journal. But it provides the exemplary status, so to speak, of the current practice of medicine. So this is how family practice, primary care physicians practice, almost by definition and almost by obligation. So in order to maintain, board certification in family medicine, pretty much the doctors follow these guidelines and have to follow these guidelines for the most part. I'm not saying doctors have a little bit of flexibility, but not a lot of flexibility, especially if they're practicing in a hospital or public clinic or something like that. Anyway, let's look at this. Non-opioid pharmacologic, so they're only going to talk about drugs here, treatments for chronic pain. So let's just look at the title of this before I get into it. So this was relatively recently published. I think this was either 2021. So this is still obviously current. And I don't have a lot to say about it, so I expect this video review to be pretty short. So let me see, what do I want to say about it? It's an efficient short review, basically documenting how family medicine doctors are supposed to implement these guidelines, but also the shocking lack of efficacy of these treatments. So this one document basically demonstrates that most of what family medicine doctors are going to do for chronic pain doesn't work. So you don't have to be a conspiracy theorist to say, oh, well, medicine sucks and medicine doesn't really work and they don't know what they're doing. I mean, this document proves those facts. It proves that they have no understanding of pathophysiology of chronic pain, and they're just basically pulling whatever drug off the shelf that's convenient, basically. So again, non-opioid drugs. Now, yeah, so they're basically going to limit the conversation to prescription drugs that aren't opioids, okay? Anyway, the topics covered here are chronic neuropathic pain, fibromyalgia, inflammatory arthritis, specifically ankylosing spondylitis and rheumatoid arthritis, osteoarthritis also, low back pain, and I guess as a treatment document, this article is horrible. If we were to say, well, they weren't trying to cover everything, they're only trying to cover the drugs that are not opioids, it's a competent review, obviously, otherwise it wouldn't have been published by the American Academy of Family Physicians. But again, it just shows that they don't know really what they're doing, and they're just reaching for whatever's convenient. So a lot of times what I see, and the way that I interpret what I see in medicine, is they adapt the practice of medicine. The practice of medicine becomes basically whatever is the convenient drug to prescribe for whatever the condition is. It's not based on understanding the condition and then doing what's appropriate for the condition. It's based on looking at what drugs are available and then saying, well, I guess we'll do that, but not really making sense of it. Oops, sorry. I just lost the page I was working on. There we go. So I'm not exactly sure how to review this. I'll just go through some of the topics, and I'll post the article. The article is available for free, so I'll post it on the website obviously, as well. The treatments they discuss here are anticonvulsants, antidepressants, NSAIDs, non-steroidal anti-inflammatory drugs, memantine, which is an anti-glutaminergic drug. They use antidepressants here, either SSRIs or SNRIs, which again shows they have no idea what they're doing. I mean, why would they use these drugs in these ways for these conditions? It's just ridiculous. It just sucks. So, this is the carrot on the end of the stick. After busting ass, let's say, for 4 years in undergraduate school, going through the absolute ringer in medical school for 4 years, and then going through family practice residency, working, 120 hours per week for 3 years to become a family medicine doctor. This is the reward that you get, is to practice cookie cutter fast food medicine that ultimately doesn't really work. So let me see if I want to say anything else about this. Some definitions here. They quote the CDC. CDC is irrelevant. So is this other organization. And then they talk about the effects of these treatments in clinical trials. And you'll see that most of them have only 1 or 2 dots, which means they're either minimally effective or moderately effective. The only treatment that gets 3 dots was for short-term pain relief in osteoarthritis using a drug from the antidepressant class. That's the best they can do? I mean, that's just horrible. Look at most of the results here. Most of the results, let me see if I can highlight that. I might not be able to highlight it using, I guess I can, but it's just kind of slow. Look at the long-term pain relief and inflammatory arthritis. Look at most of the, excuse me, most of the evidence provides no support for these treatments. And these are multi-million-dollar industries in the United States, and they have no supporting evidence for long-term use. And they're prescribed long-term. Neuropathic pain. They talk about capsaicin and cannabis. Usually the way they do those trials is they design the trials to fail, so that's why they show no evidence. Moderate evidence with memantine and fibromyalgia. Ridiculous. Not horribly ridiculous if you understand the mechanism of action in that disease, but it's obviously not addressing it's not addressing either the primary or the secondary events in fibromyalgia. So if it works at all, it's never going to cure the disease. Again, if we look at this page, short-term, very small benefit to the vast majority of drugs. These are mostly focusing on NSAIDs, even though this table isn't very well described. But look at the evidence. Let me see if I can highlight this. This is probably worth highlighting, even though this program is kind of slow on the highlighting. No evidence. And then what do I have to do? Let me see if I can do this faster. No. So I have to do this every time. No. So I'm just going to highlight the ones that are no or very small evidence of benefit. Let me do it that way. So let me go back. I think that's probably the best way to do it. And again, these are drug studies by medical doctors conducted by medical schools that are funded by drug companies. So whatever little bit of evidence that they show is probably an exaggeration. So I'm just going to highlight the ones that are either small or none. And that one only got one circle, even though it says moderate. I'm gonna highlight it anyway. So look at actually all of these are, the whole table is this way apparently. I guess I have to highlight the entire table on short-term function, intermediate-term function, long-term function, short-term or intermediate-term quality of life. Everything on this page is either no evidence or minimal benefit. I thought I was going to have to be selective and pick out the ones that worked and the ones that didn't, but none of them worked. Everything on here is small, no evidence, none. Even the ones they say moderate only got 1 star out of 3, so to speak. Everything else is no evidence, small or none. So imagine having gone to 4 years of undergraduate, 4 years of medical school, so that's 8 years, 3 years of hospital training, somewhere between 80 and 120 hours per week, which means that within your 3-year residency, you either worked the equivalent of 6 years or 9 years. So basically, you're looking at 14 years worth of work minimum to be a family medicine doctor. Yeah, 14 years of work. And this is what you get to do. You get to follow guidelines that show no or minimal benefit. Same thing here. For neuropathic pain, fibromyalgia, osteoarthritis, low back pain, again, neuropathic, fibromyalgia, inflammatory arthritis. You get to do this, which mostly shows minimal benefit, and none of these interventions actually address the problem. So the only short-term Band-Aids you're condoned and allowed to use, the short-term Band-Aids basically don't work, and that's all you're allowed to do in a standard practice of family medicine. Again, this is published in the journal American Family Physician, 2021, published by the American Academy of Family Physicians. This is what you get to do after working horribly hard and sacrificing most of the rest of your life in terms of other aspects of your life, your own health, your family, your pets, your other interests. You sacrificed everything for 14 years, and this is what you get to do. And none of this, at any point in time, none of this addresses the underlying disease. This was an interesting statement here, which actually contrasts quite interestingly with another article published in the same journal, also in American Family Physician. But the article that I'm mentally referencing was published in about 2003, more or less. Could have been 2002. So I just want to point this out. NSAIDs exhibited moderate, short, and long-term increases in serious gastrointestinal adverse effects. That's among the understatements of the decade. NSAIDs exhibited moderate, short, and long-term increases in serious gastrointestinal adverse effects. In that one sentence, they just whitewashed the injury, hospitalization, and deaths of tens of thousands of people in the United States every year. So, like I said, another article published in the same journal about 20 years ago stated that NSAIDs were either a leading cause, but probably the leading cause of gastrointestinal hemorrhage, resulting in tens to hundreds of thousands of injuries and deaths every year. And they said that the problem was so big that if they basically said this, they basically said that if we were to look at the real numbers, the numbers would be quote unquote overwhelming from the adverse effects of medical interventions every year. Specifically, they were referencing gastrointestinal hemorrhage from NSAIDs. And look at how that same topic reviewed 20 years ago got whitewashed here. NSAIDs, I mean, look at how benign this sentence is. NSAIDs exhibited moderate, short, and long-term increases in serious gastrointestinal adverse effects. You're talking about hemorrhage and death for tens of thousands or hundreds of thousands of people every year, simply within the United States. We're not even talking globally. And here they said, oh, moderate increases in serious gastrointestinal adverse effects. They didn't even say what the adverse effects are. Like, you're just talking about a little tummy ache? No, you're talking about life-threatening hemorrhage. So again, imagine working for 14 years of your life to do this, to practice in this way. And the other thing, look at what they say here. The American Academy of Family Physicians endorses the American College of Physicians 2017 clinical practice guidelines on treating low back pain, a large percentage of which is caused by vitamin D deficiency, which recommends NSAIDs, and they don't even talk about vitamin D here, which recommends NSAIDs or skeletal muscle relaxants, followed by tramadol or antidepressant drug for patients who do not tolerate or respond to NSAIDs. And that's just absurd. So most patients with low back pain don't need muscle relaxants. If you look at most patients who have chronic low back pain or even acute low back pain, they have muscle weakness and muscle imbalances that leads to their low back pain. So here we're talking about chronic pain. Most patients with chronic low back pain have muscle weakness and muscle imbalances. They don't need a muscle relaxant, which is just going to make their weakness and imbalance even worse. So again, that's just another example of how these guidelines, the standard medical guidelines commonly, and especially in the treatment of pain, commonly have nothing to do with the underlying problem, and sometimes they actually make the underlying problem worse. And this article, which I didn't necessarily expect this. I just read this article right now. This article exemplifies the tragedy of the practice of family medicine. When doctors are forced to practice, in a way that is guaranteed to fail them as clinicians and to fail patients as well. So this is why we collectively, and this is why I'm working on, some new models and paradigms and protocols for the treatment of chronic pain, because this is the fate of hundreds of thousands of doctors to practice in this utterly ineffective and miserable way. And for millions of their patients, this is what they're going to get. Utterly ineffective and potentially dangerous treatments. And this is the highest level of family medicine practice. I mean, this is what family medicine practice doctors are expected to do. I mean, look at the lead authors on this paper. The lead authors on this paper are fellows of the American Academy of Family Physicians. So, I mean, this is 100% representative of the American style of practicing family medicine, and in other countries as well. And it's guaranteed to fail. It's going to fail the doctors who do this because they won't be successful, and it's going to fail the patients who receive this treatment. So I'm going to stamp this as a complete disaster, and it's highly representative of the current practice of medicine. Thank you very much. This has been Dr. Alex Vasquez at inflammationmastery.com and healthythinking.substack.com. Thank you much. Bye.